Greetings, and welcome to another installment of Optimal Anesthesia, in which we discuss current issues in the anesthesia community. We'll be discussing upper airway obstruction, a crucial part of anesthesia, today. We will examine the impact of anesthetics as we learn about the causes, evaluation, prevention, and therapy of this potentially fatal condition. What are we waiting for? Picture this: your upper airway is like a well-orchestrated symphony, with various parts playing different roles. But during anesthesia, this symphony can sometimes turn chaotic. There are 5 key players in this drama. The velopharynx, it's small and flexible, often the first to collapse. The oropharynx, it's in the middle, can collapse too. The hypopharynx, it's bigger but less compliant. The retrolingual region, it's behind the tongue and is a frequent culprit. And finally, the nasopharynx, it connects your nasal passages to your throat and is less prone to collapse. Upper airway obstruction during anesthesia is not to be taken lightly. It can lead to a series of life-threatening dangers. Hypoxia, low oxygen levels, can cause brain damage, cardiac arrhythmias, and even cardiac arrest. Respiratory distress, the struggle to breathe, can be terrifying. Hypercapnia, high carbon dioxide levels, can lead to respiratory acidosis, a life-threatening condition. Cardiac complications, stress on the heart, can cause increased heart rate, high blood pressure, and cardiac arrhythmias. Aspiration of gastric contents, it's like a recipe for aspiration pneumonia and severe respiratory distress. Cerebral hypoxia, lack of oxygen to the brain, can lead to confusion, loss of consciousness, and neurological damage. Cardiac arrest, untreated severe hypoxia, can be a life-threatening emergency. Delayed emergence from anesthesia, prolonged anesthesia, can result in delayed recovery and increased postoperative complications. Anoxic brain injury, long-term and severe hypoxia, can lead to lasting neurological problems. Patient morbidity and mortality, in severe cases, it can result in long-term health issues or even death. So, how do we diagnose upper airway obstruction? It's a bit like detective work. We gather clues from various sources, listen for unusual breathing sounds like snoring or stridor, consider physical indicators like obesity, and ask about symptoms of sleep apnea. Think of it as getting an X-ray of the scene. CT and MRI scans provide detailed anatomical information. Lateral cephalometry helps us check out your craniofacial structures. Endoscopy, it's like a mini camera tour of your upper airway. And flow volume curves, they reveal airflow dynamics, almost like checking the traffic flow in a city. Now, let's meet the culprits. What makes upper airway obstruction more likely during anesthesia? If you have narrow airways or increased flaccidity, you're more at risk. It can even lead to life-threatening hypoxia and cardiac arrest. Neuromuscular tone, reduced muscle tone during anesthesia, can cause a complete blockage, leading to life-threatening anoxia and organ damage. And then, there's the anesthetic agents. These can be your friends or foes. Different anesthetic drugs have unique effects, some of which can be pretty tricky. Neuromuscular blockers, these agents can profoundly inhibit skeletal muscle activity, making breathing difficult and increasing the risk of life-threatening oxygen desaturation. Sedatives and opioids, they can inhibit upper airway muscle activity, which contributes to life-threatening obstruction and critical hypoxia. Now, inhalation anesthetics, their effect varies with concentration, potentially leading to life-threatening obstruction. Intravenous anesthetics, they have a hierarchy of effect on upper airway muscles, with the potential for life-threatening obstruction and severe complications. And finally, there's ketamine. It's a bit unpredictable, with varying effects that can lead to life-threatening airway compromise and emergencies. But don't worry, it's not all doom and gloom. We have ways to prevent and manage upper airway obstruction. Anatomical positioning and posture. Sometimes, just adjusting your head position and posture can promote airway patency, reducing life-threatening risks. Continuous positive airway pressure. CPAP. Imagine applying positive pressure to your airway, like a gentle breeze that keeps the road clear, especially helpful for patients with sleep apnea. Mandibular advancement. Repositioning the jaw can increase airway patency, preventing dangerous oxygen desaturation and averting life-threatening complications. When all else fails, we have treatment strategies. Tracheal tubes. They're like the gold standard for controlling the airway during anesthesia, but we need to be careful with anesthetic drugs to prevent life-threatening complications. Fiber optic endoscopy. It's like a specialized camera tour of your upper airway, especially useful when we expect a difficult intubation. Laryngeal mask airway, LMA. These provide a reliable conduit to maintain a patent airway without extra maneuvers, potentially preventing life-threatening desaturation. In severe cases, we might even consider transtracheal techniques, like a tracheotomy, to establish an emergency airway. But we always consider the choice of anesthetic agents to mitigate life-threatening risks. And lastly, there's Heliox, a mix of helium and oxygen that can relieve respiratory distress caused by turbulence in extremely narrow airways, potentially preventing life-threatening respiratory failure. And there you have it, the intricate world of upper airway obstruction during anesthesia. It's not just about surgery, it's about patient safety and life-saving measures. So the next time you have a patient under anesthesia, remember, a clear airway is your best ally. Thanks for joining us on Optimal Anesthesia. Stay safe, stay informed, and breathe easy.